Your dad, his shoulders come out when he's playing. We're going to talk about the glenohumeral joint and the acromioclavicular joint. So, things I'm going to cover very briefly. What are they? What are the red flag signs? In other words, what must you not sit on? And then what are some of the current treatment options available for these conditions? So, for those of you not used to looking at x-rays, the one on your right, can anyone tell what's wrong with that x-ray? There's a clue in the name of the talk. So that's a glenohumeral joint dislocation. It's gone out the front. It's the commonest one that we'll see. About 85% of all dislocated shoulders will be from the front traumatically. And it's the most commonly dislocated joint. We'll all know someone who's had a dislocated shoulder at some point, I'm sure. The one on the right is slightly more uncommon. This is actually an acromioclavicular joint. And the classic appearance when people see them is you see you've got this raised lump on the shoulder, and it always looks prominent. Just a little nuance. It's not actually the bit that's raised. It's actually the arm that's dropped away. But it just looks that way. And again, that's a type of dislocation. So, I've covered the fact that most of them are traumatic. There are some subtle ones which aren't, which we can discuss in a separate scenario. I want to concentrate on the main types of dislocations that we see. The important thing to be aware of with the dislocation is that they need an emergent review. In other words, same day, straight away. If it's a first-time traumatic dislocator, you do not leave it till the next day. One of the problems we have locally, unfortunately, our A&E is closed out of hours. I have seen 3 patients in the last year who stayed at home with dislocated shoulders because they did not want to travel to have their arms put back in. They've all recovered, but they all had nerve injuries which could have been avoided for timely intervention. So if you see someone in the morning of a clinic, get them down to straight away because time is critical with these. That's the take-home point for the talk. I could sit down now. That's all I really need you to know. And again, this slide, so if you can't read at the back, I've basically said, what do you do with a glenohumeral joint dislocation? You reduce it emergently. The next line, what do? You reduce it emergency. The third line, what do? You reduce it emergency. You get the gist. Yeah? Now, this is the bit where it gets difficult. All right, I've put it back. Now what? So it depends on the age of your patient. Patients who are traumatic dislocators have been given criteria of how we should treat them based on their age according to our British Elbow and Shoulder Society's guidelines. If you're under the age of 25, the likelihood is you will probably end up with another dislocation, but for a first-time dislocator it's worth seeing them, give them the option of physio and talk to them about the risk of having a dislocation. The 25s to 40s, much like real life, because you're too busy looking after kids and working, no one really cares. They sort of end up in default somewhere in the system, and only very few will actually get triaged to see a specialist if they've got a very special interest like elite sportsmen and women. The over 40s is where trouble starts, because when you're younger, you're loose, you're flexible, you're supple. When you get old, you get stiff. When you get stiff, your labrum in your shoulder joint doesn't tear, but your rotator cuff does. And as we've talked about briefly at the tail end of the questions, if you have a rotator cuff tear from a traumatic incident like a dislocation, it's time sensitive to get the best result for the patient. So what you don't want to do is inadvertently put someone into a 6-month wait and see pathway, having dislocated their shoulder and torn their cuff, because we might not be able to get them right if they come to us late. So that's the other group to be aware of. It's summarised in this flow diagram very basically. The essential points here for those of you who do work in an A&E environment is that if you see someone who looks like they've had a shoulder dislocation, please get an x-ray before you try pulling it back. I worked very hard when I was in London to put a reverse shoulder replacement in the patient, but it leaves them with a slightly dimpled area in the shoulder, which sometimes looks like a patient with dislocation. A well-meaning junior doctor spent an hour trying to pull out my reverse shoulder replacement from this patient. So if they've got a scar on the arm, just let that be a warning point to you before you try reducing it. And then these pathways are just showing that the younger patients should be seen by a shoulder specialist early. The older patients, over 40s, not that that's old, but in terms of the cuff group, should be seen within the first 6 weeks. And the 25s to 40s can usually manage conservative treatment with physiotherapy. However, there's a nice question, which is how much physio, who should do it. And at the moment, I'm very pleased to say that the Lincolnshire Elective Orthopaedic Institute is taking part in a randomised controlled trial called the Artisan trial, which is to look exactly at that question. Do you need physiotherapy once, or do you need several sessions to give the same result with a first-time dislocated shoulder? And hopefully we'll be recruiting patients into that in the near future, so watch this space. Is this working? Try again. Here we are. So I wasn't going to bore you with surgical videos because I appreciate we're not a room of surgeons. This was just to show the point that if you have a dislocated shoulder, you don't always tear the tender muscles at the top of the shoulder. You sometimes tear the tendons at the front. If you rip the subscapularis, if you don't repair that, that's a nightmare, because you can't do a straightforward shoulder replacement. So to salvage, you're looking at the lines of doing something called a reverse shoulder replacement. Historically, these used to be done through an open approach, but if you have experience with advanced arthroscopic techniques and you can find the axillary nerve, you can repair these arthroscopically. And this is one of the patients that we've done in Grantham who I was feeling very proud about myself until he got a frozen shoulder afterwards. But he's doing well now, I'm pleased to say. One of the patients I've treated in the past has got an unusual injury. This is something called a Hagel lesion. I don't know if anybody here has actually seen a patient with a Hagel lesion. I appreciate Val will have done. Anybody come across one of these before? Any experience? Doesn't seem to be. Okay, so Hagel stands for a humeral avulsion of the glenohumeral ligament. It is a common cause of a failure of a stabilisation procedure for someone after dislocation because it wasn't appreciated. What happens with the Hagel lesion is that the hammock, if you imagine the shoulder as being like someone's, this is the humeral head and the fist, and you've got a sling, one at the front, one at the back, and it holds it like that. These ligaments here that hold it together, if they're ripped away, what happens is when you try and bring your arm into abduction, the humeral head has to move downwards on the glenoid. If you haven't got this hammock, it drops down. So one of the ways you look for that, and we will show you that in the masterclass sessions later on, is you do what's called an axillary relocation test. And what you do is, because it's dropping away, you physically hold the arm or the humeral head into the socket, and then you abduct, holding it in the correct position, and all of a sudden the range of motion improves. You won't see many patients with that, so just to be aware of that. That test, to the best of my knowledge, has not been very well described, so I just want to try and disseminate that because it's probably worth being aware of. This is an example of a triage pathway. I won't go through it, but it should be in your handouts. Hopefully this will give you an idea of what we do and don't need to see. And then again, how do you get in touch with us?